Welcome to this GSA Momentum Discussion Webinar titled Putting the Chronic Disease of Obesity at the Forefront, Common Diseases as Manifestations of Obesity in Older Adults. GSA Momentum discussions highlight topics experiencing great momentum in the field in gerontology. We're grateful to Novo Nordisk for their support of this momentum discussion. My name is Jen Pettis, and I'm the Director of Strategic Alliances at GSA, and I'm pleased to serve as the moderator for today's momentum discussion. I'm delighted to be joined by Dr. John A. Batsis, a geriatrician and an associate professor in the Division of Geriatric Medicine in the School of Medicine and the Department of Nutrition at the Gilling School of Global Public Health at the University of North Carolina at Chapel Hill. And by Dr. Catherine Porter Starr, a registered dietitian and an associate professor at Duke University School of Medicine and a research health scientist at the Durham VA Medical Center. I'm also joined by Dr. Dennis Villarreal, a professor of medicine in the Division of Endocrinology, Diabetes, and Metabolism at Baylor College of Medicine and a staff physician at the Michael E. DeBakey VA Medical Center. Finally, I'm joined by Joe Naglowski, the president and CEO at the Obesity Action Coalition. Welcome, and I'm so glad that you all could join me. A chronic and often untreated disease, obesity has emerged as a major source of morbidity and mortality in the United States and many other countries worldwide. Additionally, obesity is inextricably linked to common health conditions such as diabetes, hypertension, high cholesterol, coronary heart disease, stroke, osteoarthritis, sleep apnea, and breathing problems, many of which are common for older adults. All too often, medical providers treat these common health conditions without addressing the common root cause of obesity using a comprehensive evidence-based approach. During this momentum discussion, our panel will share how primary care providers and others can employ the GSA KAER or Kickstart, Assess, Evaluate, Refer framework and use the tools and resources in the GSA KAER Toolkit for the management of obesity in older adults, which is available at geron.org/obesity, to address the root cause of many health conditions, which is obesity. Joe, let's start by setting the stage for our discussion today by describing the scope of the problem of older adults with obesity. Can you share some insights into the prevalence of obesity in older adults and perhaps some factors such as racial or ethnic characteristics and social determinants of health that influence the prevalence of obesity in certain groups of older adults?
Thanks, Jen. So obesity is pretty common in older adults. And in fact, if we use the BMI measures, about 43% of older adults live with obesity. And we know within that population, within subpopulations, we see even higher rates, those approaching 50% in people who are African American or of Hispanic descent. And we see higher rates, especially around severe obesity in women. And so it's important to recognize that this is a wide population that's being affected, but also really important in older adults to recognize that our reliance on BMI to determine if someone has obesity is arguably it's a flawed measure in many cases, but especially in older adults, because people as they age have a tendency to lose some muscle mass, and that may actually skew those results. So my guess is that 43% number is actually an underestimate in older adults, and we may actually see more people who are older adults living with obesity. And that's why it's so important that you not determine yourself whether you have obesity, that you actually talk to a healthcare provider around this issue and let them make the diagnosis, because it is not as simple as a number on a chart or a number on a scale.
Thanks, Joe. Dr. Villarreal, let's move to you next. When I introduced this session, I noted that obesity is directly linked to common health conditions. And as we reflect on the information that Joe just shared about prevalence, can you discuss the frequency of some of these conditions that I mentioned among older adults with obesity and how some of these common chronic diseases are inextricably associated with obesity?
Absolutely. Obesity is a common medical illness. It affects many Americans. It's as you would excess body fat. and which has accumulated to the extent that it can potentially have negative effects on health. In fact, obesity is often considered a multiple comorbid and chronic medical condition, including diabetes, cancer, and heart disease. Overweight and obesity increases the risk for type 2 diabetes and other medical conditions, including cancer and heart disease. It increases risk of type 2 diabetes, and 5 to 7% weight loss, together with moderate levels of physical activity, can decrease the number of type 2 diabetes by 58% among people at risk for diabetes. Over 80% of patients with coronary heart disease have overweight or obesity, and all components of the metabolic syndrome increase with age. Obesity increases the risk for hypertension, which causes damage to heart, brain, kidneys, and eyes. And if average BMI is reduced by 5%, over 5 million Americans would be spared for developing obesity-related hypertension. Obesity-related cancers include endometrial, esophageal, liver, and colorectal. And 55% of cancer diagnoses for women and 24% of cancer diagnosis for men are associated with overweight and obesity. 3/4 of people with osteoarthritis have overweight, and adults are up to 4 times more likely to develop osteoarthritis of the knee than adults without obesity. So in summary, older adults with obesity have approximately 8.5 times higher risk of type 2 diabetes, 6.1 times higher risk of coronary artery disease, 1.6 times higher risk of obesity-related cancers, 1.5 times higher risk of stroke, and 1.4 times higher risk of severe osteoarthritis. And a 5 to 10% reduction of body weight can decrease chronic disease risk among persons with obesity.
Thank you. Dr. Batsis, I'll turn to you now and ask you, how can addressing obesity intently improve on older adults' overall health?
Thanks, Jen, for the question, the opportunity. I think, here's a big challenge in clinical care, is that often obesity as a chronic disease is not overtly identified and managed, and particularly in older adults who have a lot of comorbid conditions. And Dr. Villarreal really highlighted very nicely the challenges thereof and the associated comorbidities. So when a patient comes into the office, you're focusing on all those other comorbidities and not really focusing on obesity as a chronic disease. And that may be a common factor and common player amongst all of them. So really want to be able to think carefully and think, how do we, as clinical providers, really are strategic in addressing the chronic disease of obesity. We know that the data really demonstrates both lifestyle, emerging pharmacotherapy, and bariatric surgery, not only in all comers, meaning all ages, but even specifically in older adults, can lead to reductions in mortality, death, reductions in nursing home placement, reduction in utilization, meaning healthcare costs, and importantly, particularly in older adults, quality of life and physical function. And these are really two major tenets when we think about the overall care of the older adult patient. When I'm with patients in my office, older adults, they not only care about their medical issues, but they also care about being able to play with their loved ones, their grandchildren, able to kind of get out and about. So this is really important for us to identify what's important to the patient and identify a strategic plan to reach those goals. It's really about, a lot of shared decision making and a lot of kind of matching priorities of managing the chronic disease with that of the patient.
So Dr. Starr, Dr. Batsis referred to quality of life and function. How can addressing obesity intently improve these?
Yeah, so he hit the nail right on the head. We know that independence is one of the most important factors in many older adults' lives. They want to remain independent, be able to really exactly get on the floor with their grandchildren, live their best life. And so as we're thinking about intently addressing obesity, I think it's really important to think about, as Dr. Batsis mentioned, the lifestyle treatments that we can actually, focus on and provide. So we do know that obesity really does exacerbate physical function, worsens frailty, and impairs that quality of life. And so we know if we can think about not only from a standpoint of just exercise, but really strength training for our older adults to really help focus on that muscle quality, that is really, really important, in addition to thinking about intentional weight loss, making sure that our individual is eating enough calories, particularly eating enough protein, so that we can really maximize muscle protein synthesis, so that when we do recommend weight loss, we're doing it in a way that we can ensure that that muscle quality, muscle strength is going to be preserved. And again, I think we do know that with weight loss, we see improvements in functionality, we see improvements in movement, we see improvements in quality of life. But again, we do have to be intentional when we recommend weight loss, and ensure that we are doing it so that we're not impacting the muscle in regards to just having someone restrict their dietary intake and not include movement, including aerobic and, importantly, resistance training.
Thank you. Well, Joe, I'm going to turn back to you now and talk a bit about, you had shared with me that the Obesity Action Coalition surveyed people with obesity across the country to understand their weight loss journeys and motivations to address their health, among other issues. What did you learn about older adults' views around obesity as a disease and their willingness to address their condition?
Yeah, we did an interesting survey at the beginning of 2023 and presented some of this data at Obesity Week in late 2023, looking at people's attitudes. And what we saw, interestingly, with older adults is that they are more likely to recognize obesity as a disease, which probably not surprising, right? And many people have lived this with their entire lifetime, they understand it's not a simple problem, it's a more complicated one. And that's usually when people relate to disease. Older adults also had the tendency to believe that their insurance should cover care for their obesity at a higher rate than younger adults. But then interestingly, the one area where we saw a little disconnect was around some of the more advanced treatments for obesity. And many older adults actually thought that, for example, anti-obesity medicines aren't appropriate, right? And I've spent a lot of time thinking about this, and we'll have to do some further survey work around this. But I suspect that's because many of our older adults have lived through the development of some of these more advanced treatments for obesity. So they probably lived through the fen-phen era, for example, where we saw a product, by the way, which was not FDA approved. It wasn't approved in combination. It was used off-label, but that it actually harmed the product that harmed people. And so we have to overcome that in older adults to realize that, that there are treatment options. And by the way, you don't have to do this, and you shouldn't be trying to address your obesity on your own, right? This is something where you need to seek health care providers, someone who specializes in this care, and to make sure that you're not doing yourself harm, as been referenced in some of the previous comments here. This is not about weight loss, right? This is about health, right? And so it's important that we don't create weight loss at any cost, right? You do not want to create weight loss and make somebody frail, right? That you're not improving their health, you're not improving their quality of life by doing so. And so it's important. There is work to be done. And I think we need to overcome maybe some of the simplistic messages that live in society right now. And I think the best way to do that is to get our healthcare providers trained around this topic, and then make sure that folks, if you're going to work to address your obesity, to address your body weight, that you first have a conversation with your doctor. I know you see that disclaimer everywhere you go, right? But the reality is that most people don't do that. Most people think they have to do this on their own. And they should, right? You need to talk to a healthcare provider if you're going to try to address your weight or your obesity.
Well, Joe, you brought me a really nice segue into our next comment, and that is about the first step in the KAER framework, and that is to kickstart a conversation about body size. Dr. Batsis, how can primary care providers and others use the GSA KAER Toolkit for the management of obesity in older adults to address some of the issues that Joe mentioned when kickstarting body size conversations with older adults?
So the KAER framework really has been an unbelievable addition to our ability to manage obesity, particularly in the primary care setting. And it's really provided some really unique tools and targeted tools for the primary care provider and clinician. I think first, before we, the kickstarting the conversation, I think we need to think about a number of elements here, and really piggybacking on what Joe is sharing about, in his comments, is thinking about, we need to make sure everybody in the office is on the same page. Obesity is a chronic disease. We really need to drill that home, not only amongst clinical providers, but amongst the support staff as well, the office staff. And that it's not just an illness, or that is, well, folks are eating too much or they have no willpower. We got to get that completely out of our minds. There's a lot of biology here that we're overlooking. So first and foremost, practically, make sure everybody's on the same page that understands that. Secondly, we need to use person-first language. Persons with obesity, not obese persons, not obese patients. And I think many of us on this call have probably been guilty of using that terminology in the past. We're getting better. Correct yourself. Even if you say it mid-sentence, correct yourself. That actually shows leadership, shows understanding that it is a chronic disease. We never say cancerous patients, for instance. So I think that's really an important, not only the documentation in the medical record, but in your verbiage in your clinical staff. Thirdly, think about your clinical infrastructure. You want to be sensitive. This is a number of older adults who may have had obesity, may have had this disease for a long period of time. So there's a lot of stigma related to the disease of obesity, and individuals and patients are sensitive to it. So you don't want to have a chair that is not friendly. If folks can't sit in it, that's a problem, and that really can really affect someone. And it may not strike us as providers so much, but it really strikes the patient. And so make sure your workflows are sensitive to the needs of patients with obesity. You want to be able to make sure that the clinic there, when you're weighing a patient as part of one's vital signs, it should be done in private. It's a health measure. Don't have a scale out in the mid-open. I can, in many practices that I've been at and I've worked in, that's the case. Why? It may be more conducive from a workflow standpoint, but really there's a significant amount of privacy. Lastly, or second to lastly, be empathetic. This has been a struggle. Patients know they need to maybe lose weight or need to get healthier. They're struggling for whatever reason that may be. Obesity is a complex, heterogeneous disease. So one person with obesity is one person with obesity is one person with obesity. And we need to think about this as a marathon, not a race. And I think that's really important for us to be able to characterize that, not only to our office staff, but to our patients themselves.
Terrific. Thank you. The second step of the CARE framework is to assess for overweight and obesity. Dr. Starr, can you address some key assessment tenets that are especially important when caring for older adults?
Yeah, absolutely. And so I think, Dr. Batsis has already mentioned this, is really, as we're thinking about assessing our patients, we also need to be thinking alignment with their goals and understanding really the 5 M's of geriatrics. And I'm going to mention this first. And again, I know that this is not necessarily assessment, but this is extremely important as we're thinking about how we're assessing our patients. And so the 5 M's are really come out from the work by Mary Tinetti that talks about what matters most, how, what's personally meaningful health outcomes, goals, and care preferences for our patients. Mobility. So really thinking about mobility of the individual and how that is going to impact the individual, and also how that aligns with the chronic health condition. In this case, obesity. Multi-complexity. We know that our older adults are complex. We know that they have a number of chronic health, could have a number of chronic health conditions, potentially have injuries, potentially have social determinants of health. And again, understanding that we understand the obesity treatment, the assessment that aligns with the multi-complexity, again, discussing the social determinants of health, access to healthy food and options. Mind, thinking about mood disorders and how that mood disorder may impact the obesity treatment, especially as we're thinking about assessing our patients, and then also medication. So again, I think it's important to set the stage that we have these things in mind when we are working with our older adult, particularly when we are going to be assessing them for obesity. And particularly, we obviously would take body weight, we'll take waist circumference, but I want to dive in even deeper and really talk about screening for potentially sarcopenia and adding in that mobility component that Mary Tinetti discusses with the 5 M's. So one of the first things that we obviously want to do is screen for sarcopenia, screen for obesity and overweight, collecting our BMI, collecting waist circumference, and looking at ethnic cut points. Additionally, we want to go a step further and screen for sarcopenia. One easy way to do that is to do the SARC-F, use the SARC-F instrument. And so that's measuring strength, assistance in walking, rising from a chair, climbing stairs, and falls. And so again, it allows the individual to be able to assess how much difficulties they have doing these. The next step with really thinking about sarcopenia is doing that diagnosis. And in the clinical setting, a way we can do that would be chair stands. So having our patients actually rise from a chair and sit back down. Being able to do that really does show that lower extremity strength. That lower extremity strength is a major predictor for functionality, for nursing home placement, for independence. And so again, that is another way that we're adding in that mobility component with our component of measurement of obesity. Again, these two things go hand in hand, as we previously talked about. Independence and maintaining functionality is extremely important. And again, lining up with what matters most to the patient is extremely important. And then again, that next step with diagnosis is actually looking at altered body composition. So that would be diving into looking at fat mass and reduced muscle mass. Again, I know that that's not necessarily something that happens in a clinical setting, particularly given the time that we have with our patients and also just the instruments that we have readily available for us to use. But if we are diving deep, really looking at using DEXA, or BIA is another, bioelectric impedance is another way that we can actually measure these things. And then finally would be looking at staging. So whether or not an individual has a presence of one complication, so metabolic disease, functional disabilities, cardiovascular disease, respiratory diseases, if they have complications, so again, that multi-complexity, in addition to decline in function, and also presence of overweight and obesity, we know that that individual is at greater risk for loss of independence. And so this is where we really need to be making sure we're very proactive about thinking about treatment strategies and how we can best align with meeting the individual's goals and also helping them maintain their quality of life as best as possible.
So we've talked about kickstarting conversations, we've talked about assessing and setting those goals with the older adults. Let's move now to the third step in the CARE framework, and that is evaluating treatment options. Dr. Villarreal, can you share some insights around supporting older adults to incorporate physical activity into their life as part of their weight management journey?
Yes, first of all, physical activity guidelines indicate that older adults should have at least 150 minutes a week of moderate intensity activity and 75 minutes of vigorous aerobic activities such as jogging, in conjunction with at least 2 days a week of activities that increase strength and activities that improve balance such as standing. If with chronic conditions, be physical activities as possible, because any kind of physical activity is better than none at all. In fact, a single session of physical activity can lead to some immediate benefits. So look for ways to increase time moving to reduce time sitting. For example, make it a tradition to walk before or after dinner. Set aside specific times to make physical activity part of daily or weekly routine, such as by keeping a physical activity diary. Start with activities, locations, and times one enjoys. Morning walks in the neighborhood, or might prefer an online class after work. Start slow and work your way up to more time or challenging activities. One may use free applications or websites for fun ways to do physical activity or new places to put variety in activity routine. So when older adults start exercise, it is recommended to play it safe and reduce risk of injury, and here's how. Begin exercise slowly with low intensity. Warm up before and cool down afterwards. Pay attention to surroundings when exercising outdoors. When exercising alone, always carry an ID, an emergency contact, and cell phone. Drink water even if one is not feeling thirsty. Wear appropriate clothes and shoes. And with specific health conditions, discuss your condition with your provider. Finally, how do we measure physical activity? Well, you can do that. It's called the whistle. So you can talk but not sing, and that's moderate activity. And it's vigorous where you're not able to say a few words without pausing for a breath.
Great advice for older adults looking to get going in their exercise and physical activity. Thanks, Dr. Villarreal. Dr. Starr, let's turn to you now to address nutritional approaches to losing weight with older adults. What advice do you share with them?
Yeah, absolutely. And so I know I have already touched on this a little bit, but it's really important as we are, again, providing recommendations to our patients about weight loss or weight loss treatment or obesity treatment, that we really do think about it in a purposeful way. I think Dr. Villarreal said this, that getting rid of these easy recommendations, and Joe mentioned this, getting rid of, like, we really need to be more purposeful about what we're telling our patients. Many times I see my patients after having seen another provider where they're just told they need to lose weight. That's really not helpful. We really need to be very mindful that when we tell an individual, regardless of their age, that they need to lose weight, a lot of times that means restriction. And so without guidance, they will restrict. So one of the ways that we can be really purposeful is making sure that we are working in an interprofessional practice. I think that is one key area that when we are recommending weight loss, particularly for our older adults with multiple complexity, multiple chronic health conditions, really aligning with a registered dietitian is a key way that we can really help make sure that we are providing some medical nutrition therapy to our patients that can be really mindful of the chronic health diseases, the prescriptions that they may be taking, and really align with meaningful weight loss. Not everybody has access to a registered dietitian, and I completely understand that. And so one of the key things that I want to mention is that we know that as we get older, we experience anabolic resistance, or that resistance to stimulating muscle protein synthesis. And so what that actually means is that as we get older, our protein needs go up so that we can actually stimulate muscle protein synthesis or make that muscle. And so when we tell someone to restrict, we really want to make sure, or have when we tell someone that they need to lose weight, we really want to make sure that they still maintain meeting their protein needs so that we can ensure that they are not going to lose that muscle mass. So really one of the things that we recommend is, and an easy way to make sure that the protein needs are being met is to consume protein throughout the day. So really trying to hit around 30 grams of high quality protein 3 times a day, breakfast, lunch, and dinner, if possible. And that's around 2.5 grams of leucine, which is really the driver of muscle protein synthesis, really stimulating that muscle protein synthesis. So if we are going to work with our patients and having them lose weight, again, doing that with, as Dr. Villarreal mentioned, the exercise component in addition to the weight loss component, really making sure that they're hitting their protein needs and understanding that protein is extremely important for these individuals, for their muscle quality, it's going to be really key. And again, I will always say that if you have the ability to refer to a registered dietitian, that is really key. We have practice. We have been trained to work with patients who have multiple chronic health conditions and really can create plans and have that time to sit down with the patient and really dive into what they're currently eating and how best to help them slowly lose that weight and keep that weight off, which is really going to be also very key.
Dr. Batsis, I'd like to turn now to you to share some of the important insights about medical and surgical management of weight approaches for older adults, weight management approaches.
Yeah, no, absolutely. And this is a really exciting time in the field of obesity medicine. I want to just, really highlight that. We have had experience over the last 20 to 25 years with bariatric surgery, even in older adults, although the proportion of older adults undergoing bariatric surgery really is about less than 5% of the entire cohort of individuals undergoing bariatric surgery. So it's not overly used, but it's effective, it's safe. Complications may be slightly higher in hospital complications, but outcomes generally are very equivocal and very similar to those in younger populations. But I would like to turn my attention really to the medication management. As Joe mentioned, there's been a long, potentially you may want to use the word checkered history, so to speak, of anti-obesity medications. And we've had some really early successes, and then we get disappointed, and then successes, disappointed. These new GLP-1 and dual agonists that are currently available for weight loss are really likely going to revolutionize our strategies. And this is almost like when you think about a pyramid, lifestyle modifications really should be the foundation and cornerstone of any type of treatment regimen. And then in those eligible and those who are unsuccessful, really the second stage is to consider medication management. These GLP-1, the data in older adults is few and far between. There are some emerging studies that are demonstrating some efficacy-based data, but a lot of the trials that really led to FDA approval did not include a significant proportion of older adults. And in particular, older adults over the age of 75. And these are the individuals who are actually at higher risk for what we call weight loss-induced sarcopenia, and importantly, weight loss-induced osteoporosis, because these are the two geriatric syndromes that are increasingly seen as one ages. So we need to be mindful of that. And the data thus far on changes in body composition as a result of these medications, again, is really, really sparse. There's only a handful of studies, and it's concerning. It's not. I don't want to paint a negative picture, but at the same time, I want to be very cautious until we get better data. And this is where some of these other adjunctive measures, protein supplementation, encouraging different types of exercise and the modality there of exercise may be helpful. But I think this is a promising time. I think individuals that are candidates for either pharmacotherapy or bariatric surgery, it needs to be an individualized decision. It's not a one size fits all. It's not a here's your medicine, go away, and we'll see you in 3 months. These patients need to be medically optimized. They need to we need to ensure that we're actually taking precautions for these potential unknown risks. And we want to be mindful of dosing as well. There was one recent study actually that demonstrated some dose dependence adverse events. So the adverse events were based on dosing in older adults versus younger. So we want to be very mindful, because a number of these adverse events are actually seen regularly in older adults, and we're just going to exacerbate them and make them worse.
Great. Well, let's move on now and talk about our final step of the CARE framework, and that is to refer older adults to resources to support them along their journey. So Drs. Starr and Villarreal, I'd love to get both of your perspectives on this. And Dr. Starr, I'll start with you. What suggestions do you have for online or local resources to support older adults on their weight loss journey?
Yeah, absolutely. And I think this is where I get really excited, because I think that there has been a big movement in evidence-based. And again, key thing here is the evidence-based, making sure that the programs that we are recommending to our patients are built on science, are founded in science, is founded by evidence. But there is a big movement on really identifying resources out there for older adults that could really help with their obesity treatment journey. I think key ones from a community set point are the why. Additionally, TOPS is Take Off Pounds Sensibly. These are now they're actually online, but these are a lot of in-person chapters throughout the country that have been really successful and really focusing on that community setting that really helps support one another through this journey of weight loss and really provides that support for healthy living and weight management. Another virtual program is Vivo, and it's an online live and interactive strength training program really focused on identifying function at the baseline and then reassessing individuals every 3 months to really look at those gains. So again, focusing on strength training, really focusing on that muscle health and muscle strength and really personalized and individualized care. Other resources that are out there, we can go to the National Institute on Aging. They have a Get Fit for Life exercise workbook that you can get for free. You can order it, and then they have a number of online videos that are available for individuals if they want to do something, you know, in their home and just do a video on their own time. So again, there are a lot of resources out there, in addition to, you know, some other technology-based programs for really thinking about monitoring nutritional intake. There's Noom, and then also MyFitnessPal. So again, some other online resources that can be used to really help with your you know, managing your dietary intake as well.
Great. Dr. Villarreal, what suggestions do you have?
Well, I can talk about 2 particular programs. If you're a veteran and you're very lucky, there's so-called the MOVE, which is the VA's National Weight Management Program developed for veterans by the National Center for Health Promotion and Diabetes Prevention. MOVE is an evidence-based self-management program that focuses on health and wellness through multidisciplinary approaches such as healthy eating, physical activity, and behavioral change. And MOVE can help one to lose weight, keeping it off, and improve one's health. And every VA medical center has a dedicated MOVE coordinator is available to assist one. So if one is interested in losing weight, then they can participate in the MOVE by talking to the local MOVE coordinator. On the other hand, in the private situation, there is so-called National Diabetes Prevention Program. This is more focused on preventing or delaying the development of type 2 diabetes, and it's a partnership of the public and the private organizations. And the partners make it easier for people at risk for type 2 diabetes, such as being overweight or obese, to participate in chronic evidence-based lifestyle change programs to reduce their risk for type 2 diabetes. They can learn about pre-diabetes, get educated, what are the risk factors, symptoms, consequences, and prevention, and they can join a lifestyle change program that provide resources in the community. And what are the eligibility to participate, and also they can be proactive by becoming a lifestyle change program provider.
Well, we've heard from our clinicians all about the full continuum of care and the importance of interdisciplinary approach to care. Unfortunately, older adults face challenges in accessing all of this great care that our colleagues have talked about. Joe, can you share with our viewers some of these challenges and what are some solutions out there, including some policy solutions that might drive change and improve access for older adults to care?
Yeah, thanks, Jen. And I think what our providers have described and the KAER Toolkit describes is the ideal scenario, right? We move people through this mechanism of care. We give people their options, and we find them the help they need, whether it's in the provider's office or in their community. But our system isn't exactly set up to do that. And in fact, most people, if they had this first conversation with their healthcare provider and their healthcare provider recommends these kind of services, they're going to run into barriers primarily with their insurance coverage, whether this is a retiree employer-based system, whether it's Medicare, whether it's Medicaid. One of the harsh realities is that all of these services aren't often available, and it's a struggle to move that through. And so we just want people to be informed, to know that this isn't easy. We are working, and I spend every day working on this issue of trying to change the system to improve access to the treatments of obesity. And the public actually thinks it's time for this to change, right? The same survey that I spoke about earlier, 80% of people now say that it's time for all these services to be covered by insurance. And so, speaking specifically of older adults, if you're an older adult and you have Medicare, you are likely to be able to be counseled for your weight by your primary care provider, and you're likely to be able to access bariatric surgery. But if you needed, for example, to see a dietitian just for obesity, that wouldn't be allowed unless that dietitian happened to work for your primary care provider. If you wanted some of the new medications that were described, those aren't allowed either. So there is actually legislation before Congress right now. It's been before Congress now for the last 6 Congresses for 10 plus years now, called the Treat and Reduce Obesity Act. We are inching closer and closer to moving this legislation forward. It's no longer a discussion about whether there's a health benefit for covering the treatments for obesity. We've proven that. We've convinced folks around that. Now it's about figuring out how to pay for it. And as you know, in our current system of government and the divisiveness in our current system of government, it all comes down to dollars. And so, but just rest assured, we are working at that. And I do think in the next several years, we are going to overcome those barriers, and we are going to see widespread access to these treatments. So then it'll be about, let's put the systems in place, let's get enough providers trained, and let's make it okay for people to seek help for their obesity. Because we've spoken a lot about the stigma of obesity, but we haven't actually talked about the fact that there's also about a stigma about needing help for your obesity. And it's important. We need to overcome that. And so if anyone here who is watching lives with obesity, I really would encourage you, if you are struggling with this issue, go have a conversation with your healthcare provider. And by the way, we heard what some of those bad conversations look like. And if your healthcare provider has one of those bad conversations with you, go find another provider who will have a good conversation with you around this. And seek the help that you need, because it's out there. Yes, it might be hard to access. I don't want any of the limitations I've talked to you about the system discourage you from doing this. It's worth trying to fight for it, and there are workarounds. And so I would encourage anyone who needs help to go ask their healthcare provider about help for their obesity.
Great. Thank you, Joe. Well, this has been a great session. We've heard a lot about individualized care and partnering with the provider, and unfortunately the barriers that older adults still face in accessing that full continuum of care. We really heard loud and clear from everyone about this is a chronic disease, and that older adults have probably faced a lifetime in many cases of stigma and bias and problematic care. But it is a new day, luckily, for obesity treatment. And I appreciate all of our experts. Thank you so much to our panelists for joining me for this GSA Momentum discussion, and to Novo Nordisk for supporting our session. And finally, I want to thank our viewers and listeners. I hope you enjoyed it, and I hope that they find, all of you who are watching, find the KAER Toolkit as a valuable resource. As a reminder, the toolkit and several other of our obesity resources are available for free, and they are available at geron.org/obesity. Thank you all so much for joining us today. Have a wonderful day.